It's 8 o'clock. Good morning, everyone. I'm Shannon Switkowski, the clinic coordinator for Cardi-OH. I will remind you to keep yourself muted unless you would like to speak. Please hit the unmute button. If you're on the phone, you can unmute using *6. We ask you to record your attendance in the chat feature with your name and your practice location. We'll go around the room here at the Cardio Hub to introduce ourselves. To my left.
I'm Jim Warner at the Case Department of Family Medicine and Community Health, and I'm a behaviorist.
I'm Goutham Rao. I'm the chair of Family Medicine and Community Health at Case, and I'm the director of ECHO.
I'm Adam Brzezinski. I'm a sociologist at Metro Health and Case Western, and I'm happy to be here this morning.
Jessie Lewis, I'm a program manager here at Case.
I'm Rick Carnaccio, the web content producer for the Cardio program.
All right, excellent. We'll start with Dr. Brzezinski. Thanks for joining us.
Sure.
Okay, turning it over to Adam. Go ahead.
Sure. So here's my disclosures. Looks like a couple others have disclosures this morning. I am going to give a brief anecdote from my book, but that doesn't mean you should buy it. So I'm going to talk about factors influencing adherence in general and hypertension adherence more specifically. And the way I thought that I would do this is to talk about some frameworks for thinking about the concept of adherence in patients with hypertension. Give some examples of how social and cultural factors influence whether patients take their medicine and adhere to other recommendations, and describe how some selected health system barriers can influence treatment adherence. What do we mean when we're talking about adherence? I think it's not always what you think we mean is what I'm really trying to communicate here. And so there are a few studies now that have shown that folks who adhere to a placebo have better outcomes than patients who do not adhere to placebo. And at first that seems like a little bit of a mind bender. And then we also know that patients who do not adhere to preventive service recommendations like cancer screening are more likely to die of non-cancer related causes of death. So like if you give yourself a minute to have that settle in, what does that mean? It means we can think of non-adherence in a couple of ways. We can think of it first as, directly causative of changes in health outcome, right? So that for a person who doesn't take a medicine that they need. So if I didn't take my antacid this morning, I would be very uncomfortable right now. That would create a sort of direct causative influence on outcome. And but it can also be thought of as a behavioral profile of non-adherence that's associated with mortality, morbidity, other outcomes. So that it's not just about like the act of adhering, but it's also about like, well, there are features that tend to be associated within a person, either psychologically, behaviorally, or socially, that come along with and are packaged with in a person who's not following through on a therapeutic recommendation. In cardiovascular disease and hypertension specifically, it is undisputed at this point that when folks do not adhere to clinical recommendations, they do worse than folks who adhere to those recommendations. And so that is for most of the primary prevention therapies and most of the secondary prevention therapies, this is well established. So if you could use a statin and you don't take it, then you will do worse than someone who takes the statin. The same goes for blood pressure control. And Jackson has talked several times about blood pressure control. Adherence is really implicated in blood pressure control. There are some review studies that estimate that as many as 40% or a half of patients did not take their medicine appropriately or at all. That number is a little bit misleading. So this is one fairly recent review study on hypertension adherence specifically. And if you can sort of scan down the far right column there, what you can see is that the non-adherence rate ranges from about 7% to 86%. So 40% is like a nice middle ground, but it really depends on so many factors. Like, what are we talking about? Are we talking about resistant hypertension? Are we talking about just uncontrolled blood pressure more generally? Are we looking at a small specific population? And how did we measure it? Are we looking at pharmacy records? Some of the nice thing about many of these studies described here is that they used a drug assay approach to assess hypertension. So you really know whether the person is on the medicine or not, as opposed to sort of more commonly used sort of claims records or self-report, or sort of even pill counting can be notoriously unreliable. And what the other thing that you see here is that the rate of non-adherence is typically established as higher when they use drug assay versus those other measurement methods. So that is another signal about adherence, which is that you can't always count on what the pharmacy fill record. Some EHRs now will tell you if the patient has filled the medicine. You can't always take that as the truth. The same as you can't always take on face value everything that the patient or their family member reports about medication taking behavior. Another really important setup, I like this figure for a few reasons, but the main one is really the top row. And it distinguishes between three different forms of non-adherence. The first is that the patient just doesn't ever start the medicine. So or follow through with the recommendation at all. The second is that there's some delay, like they don't pick it up when needed, they omit doses, they take extra doses, they don't really sort of follow the implementation that's recommended. And then the third is that they don't continue or persist in taking the medication, or they stop for some reason. And there can be very different reasons for someone to not adhere in each of those three categories. So if you imagine in the court, so the reason for someone to not start a medicine might be very different than the reason someone has for discontinuing a medication. I put this slide in here about minimally disruptive medicine from Victor Montori at Mayo, because I think it really presents an alternative framework for thinking about the problem of adherence. Montori says being a patient, especially a patient with a chronic condition, is a lot of work. When you are exhausted, frustrated, overwhelmed, fed up, disinterested, untrusting, then that can be an outcome of the medical care you're receiving, not just an indicator or a feature of a person who's non-adherent. I dislike giving too many personal examples, but I have some elderly parents with multiple chronic health conditions. I think my mother at last count has 27 medications that she takes. And she's also on dialysis. So she has like she really spends more time working to adhere to all the things that her care team wants her to do than I do in the office at work in a given week. And I think we see that a lot as patients get older and accumulate more chronic conditions. And there are lots of great things we can do for them, but those things can lead to someone being exhausted or frustrated or overwhelmed. And that is not necessarily a character flaw of a person. It could just be that there are some immense challenges here. And we really want to sort of find this sweet spot wherein the person's goals are aligned with their capacity and the doctor's goals. This was posted as a figure on a blog by one of Victor Montori's med students a while back. And I just really sort of like that sweet spot visualization for adherence. So I've done some past work in a number of settings where we collected qualitative data on multimorbidity that involve blood pressure, diabetes, lots of conditions. Most of these quotes actually come from a study of multimorbidity and epilepsy. And I think some of the things folks told us here are really fantastic. And so I'm just going to take a second and step through these. So one participant said that stress can bring on a lot of different things, high blood pressure and the works, and the next thing you know, you're a walking time bomb. So that they're sort of connecting their stress to their inability to adhere to medicine. I didn't post the sort of whole big long part of the transcript where they talked about this. Another reason folks cited for not doing what they were asked to do was they said that their care providers didn't listen to them well enough. We know that effective communication is a core component of a therapeutic relationship. And so that this can be a really tough barrier. So as soon as a person gets to that point where they feel like their care provider isn't listening, then they're going to be less likely to follow through with recommendations that you have. Cost is a well-known barrier among Medicaid patients. Most medicines are paid for, but there are other costs associated with medicines. And then there's also this sort of, there's a general, almost cultural stigma around the cost of medicines more generally, even if insurance companies or plans are covering those medications. And this participant said, what about this medication? It's so expensive, you're going to have to order it from Canada because it's $700. This side effect statement is one of my favorites in here. I've been on many medications. They've caused vomiting, they've caused bad rashes, they've caused all kinds of they've caused stumbling, they've caused, where I felt like suicidal type things, and I stopped them immediately. They've caused frustration, not being able to sleep. So this person is just sort of going through. They've been on a lot of medicine. And so it may not matter from the point of view of a person who's taking a medicine that the pharmacology, the studies, that the medicine as a provider is very well tolerated, right? But the patient does not have the same depth of understanding in many cases that a well-tolerated medicine is going to cause very few side effects in very few people. And so what they have is a personal sort of N of one biographic history of taking medicine. So it may not matter that they were on a medicine that they needed at some point in the past that caused them all kinds of problems. They just may associate that experience with any new medicine or recommendation that they're getting from any provider. It may not have been in your care specifically. It could have been in someone else's care. And then this last one I think is so common. And it's the fact that you don't want to take your pills. It's the fact that you're just so tired of seeing or hearing that alarm. You're tired of seeing that note. This is somebody who obviously, I think this one says, this is somebody who was so committed to taking their medicine that they had set themselves alarms. They had put notes around the house on the bathroom mirror, like, I really don't want to. So they didn't have most of these other barriers. They're not talking about communication or cost or side effects or stress. And they're really just saying, like, look, man, sometimes I just don't want to do this anymore. And I think that really fills in nicely with the Montori approach about minimally disruptive medicine. And so one thing to keep in mind is that patients have to integrate your recommendations, not just into their day-to-day life, but into their personal biography. I like to pause here. There was an ad by CVS that ran somewhere around 2 or 3 years ago, and it might be my favorite ad ever. I sort of looked for it. I couldn't find this ad. And the ad shows a bunch of folks of different backgrounds and different ages, sort of waking up in the morning, looking not their best, rolling out of bed and reaching, a sigh on their face and reaching for that bottle in the cabinet and just grabbing it. And it's a very empowering video because it's sort of, saying, like, we're all in this together. Like, everybody is stuck taking medicine for different kinds of things. There are some parts of it that we may not like, but we're going to do it. It's sort of focused on the grit that is sometimes needed in a person to get through those daily challenges and really integrate the fact that, like, yeah, I have some diseases and you know, and I'm going to do my best to take care of these diseases. And so I really love the spirit of that video and that approach to thinking about adherence, as opposed to what I think is a sort of legacy in behavioral medicine from, say, 50 years ago, that really frames patients as not as compliant or non-compliant, and sort of puts this. And I think some of it comes from this definitional research that I mentioned in the slide previously about thinking about non-adherence as a character flaw, because I think that's a very dangerous and not really appropriate at all way to think about it when someone's not taking their medicine. This next study is another qualitative study we did here in Cleveland with a group of young men. So everybody was between the ages of 40 and 60. And they had all had a stroke previously. And we asked them about, well, what are the reasons that you might not do the things that your doctor asks you to follow through on? And then we mapped their responses onto all of the recommendations and the predictive coefficients for that would predict whether they would have another stroke. And this first one, I think, is a nice one in the top right there, because this gentleman was really talking about what I would describe as a structural barrier. Man, they're scheduling. I'm almost at the end of my medication. I'm like, oh God, I need a refill. And so this is somebody who has been through a stroke, who maybe has some partial aphasia that is still going on, and really does not want to have that stroke again, and is deeply committed to taking medicine. And he's describing a structural barrier, like, look, I can't get an appointment that I need to get this refill. Maybe he's not able to get it. Phone conversations can be tough for folks post-stroke who have aphasia. So that is a very real struggle. And so here we're talking about a situation that is about access in your clinic, and may have very little to do with some character component of a personal decision. And I think of all of them, I like that one the most. The others in here are useful. The one that is the most worrisome is probably the second quote on here. Sometimes I think of the doctors as just using us as a paycheck. If you get sick, who are you going to go see? Your doctor. Who gets paid? Your doctor. If they write a prescription for you, they get kickbacks. Now, I know that Dr. Rao and Dr. Wright are not in the position of getting kickbacks.
You have to include Dr. Boland.
Dr. Boland is also on there. The rest of you, I'm not totally sure, but because I don't know you that well. I have a pretty good guess that none of you are getting any sort of kickback, or have you ever received a kickback for prescribing a medicine. On the other hand, this was not that long ago. This wasn't a 15 years ago quote from a participant. This was a person that you might encounter any day in your offices across the state of Ohio. This could be any Medicaid patient in Ohio. I don't think this is some aberrant view. There is a sort of street level wisdom that says, man, there is something going on in this medical system. These doctors are making a lot of money. And so that really is exposing a lack of trust. And it's really incumbent upon us as the care system to do better at building trust. That's really the only pathway, is to build trust to sort of overcome that suspicion. And then this last one, I mentioned that I take an antacid. And this is not specifically about hypertension. And I'm guessing when I sent this around to my colleagues, they're like, man, what is this doing in there? And the reason it's in here is that it's actually one of my the favorite projects that I've ever worked on in my career. It might be the simplest and most interesting randomized controlled trial project I've ever seen. All we did was we looked for patients who were coming to the outpatient clinic who had a diagnosis of GERD and still had GERD. We're dealing with GERD symptoms. So everybody their GERD was not controlled. We had a little bit of run-in for the first 2 weeks, And then, and folks were randomized, but we didn't do anything for them for 2 weeks. And then at that point, we did one thing. And the title here says optimal dosing, but that's sort of a misnomer for what we actually did. All we really did was we had a resident after the visit do one of two things. The resident could give a brief written instruction to the patient that was consistent with what they probably received from the doctor, or they could tell the patient, you know, you really should take this medicine either 30 minutes before your breakfast or with your breakfast. And if you don't take it that way, it's not going to work as well. And your symptoms are probably still going to be there. And if you really don't like those symptoms, then you really want to take this medicine with breakfast. And so what we see there is the dotted line are the folks who didn't get that. And so it literally took as long, it was about a 45-second intervention. And by doing that, you see the sort of gray line was the group where we talked to them at week 2, and by week 6, we've cut their symptoms in half. We sort of had this staggered design where 4 weeks later, we crossed over another half of the participants to get have that same conversation with a resident for 30 seconds. So I'd like to show this because sometimes I think we overthink how difficult it is to help someone understand that there are benefits to taking medicines the way that the way that you are recommending. And sometimes we just don't take the time that is needed to have that 30-second or 60-second additional conversation. The other thing, note about the study, there were 60 patients in it. It cost us like almost $0 to do. The door-to-door, I think the whole thing was done in 15 weeks. It probably took us 2 years to write about it. So I like it for that reason. Oops, wrong keyboard. So that's a nice intro to this slide, which is that there are simple strategies that have been proven to improve adherence. One is that treatment priorities should be the patient's priorities. And that, like, if you don't know what the patient's priorities are, you need to find that out. And this can be difficult in primary prevention of cardiovascular disease. So for hypertension, people don't really feel symptoms. It's not like GERD. You don't necessarily feel that your blood pressure is higher. And it really takes some trust and some conceptual understanding that controlling your blood pressure has long-term benefit for you. So I think getting to the point where the treatment priority is the patient priority takes a little bit more sweat in hypertension than it might in some other conditions where you're feeling a benefit to a medicine. Using the teach-back method, which I think we may have talked about before, really making sure you're informing patients of the benefits of medicine and aligning plans to patient goals and motivations via approaches like motivational interviewing. I said we were going to have a case from my book. So this is a 72-year-old Indian female with history of asthma, hypertension, hyperlipidemia. She was seen in the clinic for a follow-up by my colleague, Dr. Saeed. She consistently had high blood pressure, systolic over 180 at multiple visits, despite, sort of bringing her back in a protocol. Every 2 to 4 weeks, she's coming back, and her blood pressure is still high. We're adding new medicines. Her son was coming with her, and so they did this sort of family interpretation thing. Dr. Saeed called his colleague, Dr. Gill, who speaks Hindi, and was a little more familiar with her cultural background, and managed to discover that the patient was only taking medications on days that she did not feel well. As I just mentioned, hypertension medicines are generally not associated with feeling better when you take them. There might be some scenarios where that's true, but generally that's not something we associate with antihypertensives. She was explained that the need to take the medicine daily and did that in a manner that recognized the cultural value she placed on really sort of conserving resources. I actually talked to Dr. Gill about this, and she said that the patient said, you know, it wasn't that she couldn't afford the medicines. It was that she just felt that it was wasteful to take medicine if your body didn't tell you that you needed the medicine. And so it really took, this wasn't a simple conversation. It took some dialogue to convince her that she wasn't being wasteful by taking the medicine every day, even though she wasn't feeling well. You know, within a couple of months, she had a pretty substantial, 40 point or more drop in her systolic blood pressure. So in summary, a lot of patients with high blood pressure simply do not take their medicine. But not taking medicine is really best thought of as a highly individual decision that can be influenced by many factors. So not a character flaw. It could be community factors, social factors. There can be medical factors. Some folks might be diagnosed with a new condition. Maybe they had a hospitalization while they were on vacation and you don't know about it yet. And there's you have a short visit, and sometimes it can be tough to really disentangle what the reasons are why somebody discontinued a medicine. There could be historical reasons that are entrenched in the relationships between cultural groups. There are certainly behavioral reasons. Financial reasons are common, and the financial reasons can be, I didn't have enough money to take the bus to the pharmacy. They don't have to be simply about the cost of the medication itself. There can be environmental reasons. Some folks may have challenges with what their home or living environment is. If someone is mostly homeless and they're couch surfing between friends, it can be far harder to get into a regular medication routine when you don't really have a stable place to live. And there can also be interpersonal reasons. One of the groups that in the literature is least likely to take their medicines are folks who are caregivers for another person who is really not well. Caregivers are notoriously bad at caring for themselves. So sometimes a person who has a lot of empathy and is really providing direct care for a spouse, partner, or child might be also a person who's struggling with a therapeutic routine that we've asked them to follow through with. So in summary, care teams really can work together with their patients to reinforce a healthy pattern of medication taking and reduce blood pressure. And that's all I've got. I think we're just about on time for hearing the cases you guys have to talk about today.
Thank you, Adam. You can maybe just have a couple minutes for questions before we go to Dr. Boyd's case. So great presentation. Having cared for underserved populations now for about 25 years, I've noticed that we talk about non-adherence, but there's a lot of folks, including some pretty old and sick people, who take every single medicine on time, every single day. Their hemoglobin A1C is perfect, their blood pressure is perfect. What is different about them? And there's a lot of them.
Yeah, so, I think the concept here that people use to describe that is positive deviance. There have been some studies that established two really important features there. Mm-hmm. One is health literacy. So those folks tend to have higher health literacy than folks who don't take their medicine, which suggests that there is a capacity to understand the risks and benefits and make an informed decision about taking medicine. Another is trust. Like those patients almost always have a far more trusting relationship with their care team than patients who are not in that situation. And then another, even though I don't think that we should think of medication taking as a character flaw, but the psychology on this is, and Jim could potentially provide some input, is very clear that there are psychological traits in a person that are clearly associated with following through with medical recommendations. That is pretty well established. And then another is there are some components of personal resilience that people build up in all aspects of their lives. And I think that those features of resilience, some folks go through things and do well, and
Right.
other folks go through things and do less well. And I think we actually don't have a great understanding of why that's true in many arenas. But I think that those, so trust is definitely in there. A person's fundamental psychology is in there.
Mhm.
And then really what they know about health and medicine.